Before viewing this month's online CPD, please make sure you answer the pretest. This is to assess if there is enhancement of your individual continuing professional development. Hi everyone, I'm honored to have been invited by the Philippine Pediatric Society Southern Tagalog chapter to share with you another infectious disease which is close to the heart of many pediatricians. I'm Dr. Nancy Nazaire Bermal, a pediatrician, pediatric infectious disease. Our topic for today is about dengue. We have aptly titled the lecture, Pangangalaga ay hindi biro, mula ngayon hanggang bukas. Before I proceed, please allow me to acknowledge the Pediatric Infectious Disease Society for sharing most of the materials used to come up with this lecture. The PEDSP clinical case management was conducted for 2 days, encompassing topics from epidemiology to prevention, including vaccination. For the purpose of this CME activity, the following are the objectives: to describe the clinical course of dengue, to explain the World Health Organization case definition comparing the 1997 and 2009 classification, identify the differential diagnosis of dengue with focus on conditions that mimic febrile and critical phase of dengue, discuss the management of dengue with and without warning signs, and to discuss the management during convalescent period or the aftercare management. To jumpstart the discussion, may I request you to provide your diagnosis for a 15-year-old girl who was previously healthy, presenting with high-grade fever, weakness, headache, poor appetite, vomiting, and persistent abdominal pain. There was no manifestation of mucosal bleeding. On physical examination, there was hepatomegaly with tenderness on the right subcostal area with ascites. On auscultation, there was decreased breath sounds on right lower lung field. The tourniquet test was positive. Capillary refill time was prolonged at 3 to 4 seconds. Initial CBC showed hemoglobin of 110, hematocrit of 0.43, the WBC count was low at 4, and platelet of 100,000. What is your diagnosis, please? I hope you were able to recognize the salient information to arrive at the correct diagnosis. As we go through the discussion, please remember this case, and I will give you the final answer at the end of the lecture. To be able to properly care for our patients with dengue, there is a need to understand the disease, the course, and the appropriate management. Dengue is an illness caused by a virus transmitted by Aedes mosquito, which has a distinct physical feature, that of a black and white stripes on its body and legs. The mosquito bites during the day and lays its eggs in clean, stagnant water, which could be lying around our houses. There are 4 types of dengue virus causing the disease, which are dengue virus 1, 2, 3, and 4. The incubation period of dengue is usually from 4 to 7 days. What happens next after the mosquito bites and incubation period of 4 to 7 days? Patients will present with the different manifestations which can be used to classify the severity of dengue hemorrhagic fever. I will now discuss the grading severity used by the WHO in 1997. This grading severity relies on the different signs and symptoms as well as laboratory results. Please note that laboratory profile are all the same from grade 1 to grade 4 with platelet count of less than 100,000 an increase of 20% in hematocrit. For dengue hemorrhagic fever, the signs and symptoms include non-specific constitutional such as anorexia, vomiting, abdominal pain. Tourniquet test is positive, which is the only hemorrhagic manifestation. For dengue hemorrhagic fever grade 2, patient will present with symptoms of grade 1, now with spontaneous bleeding from the skin or the gastrointestinal tract. For dengue hemorrhagic fever grade 3, in addition to the grade 2 manifestations, patient has circulatory failure presenting as weak pulses and narrow pulse pressure, hypotension, and restlessness. For dengue hemorrhagic fever grade 4, patients will have profound shock with undetectable BP and pulse. In the 1997 classification of dengue hemorrhagic fever, hemorrhagic tendencies, thrombocytopenia of less than or equal to 100,000, and evidence of plasma leakage must all be present before you can make a diagnosis of dengue hemorrhagic fever. If patients will present only with fever and other constitutional signs and symptoms, diagnosis given is dengue fever. Comparing this to the new dengue classification released by WHO in 2009, based on the confirmatory test, dengue is classified as probable dengue and confirmed dengue fever. For probable dengue, the following are the criteria. Patient lives in or travels to dengue endemic area with fever plus any two of the following: headache, body malaise, myalgia, arthralgia, retroorbital pain, nausea and vomiting, anorexia, diarrhea, flushed skin, rash which can be petechial rash or Hermann's sign, and a positive tourniquet test. Plus, in the laboratory test, at least a CBC which can show leukopenia with or without thrombocytopenia. Please note that it is important to highlight or focus on the WBC count instead of focusing to the platelet count. Also, in this classification, you may request for dengue NS1 antigen test or dengue IgM antibody test, which are actually optional in the diagnosis. For confirmed dengue fever, you may request for viral culture isolation or PCR, which are both available locally. The new dengue classification highlights on the presence or absence of warning signs. What are these warning signs? I hope you will remember this because this will be important in managing our patients with dengue. Abdominal pain or tenderness. Your patients can have mucosal bleeding, clinical signs of fluid accumulation, persistent vomiting, lethargy and restlessness, liver enlargement, decreased or no urine output within 6 hours, and if you do a laboratory examination, there can be increase in hematocrit and or decreasing platelet count. For severe dengue, aside from living or traveling to endemic area, fever of 2 to 7 days, patients will have any of the following clinical manifestations for dengue with or without warning signs, and patient will be presenting with the following manifestations. 1, there can be severe plasma leakage, which can lead to shock, fluid accumulation with respiratory distress, Patient with severe dengue will also have severe organ impairment, which you can check by having your liver function test. If you check the central nervous system, patients with severe dengue may have seizures or impaired consciousness. Likewise, patients with severe organ impairment can also have myocarditis or even renal failure. The other presentation of severe dengue is severe bleeding, which can be from gastrointestinal tract, most commonly from the gastrointestinal tract. Looking now at both the 1997 and 2009 classification, the 1997 classification provides rigid criteria where all 4 criteria should be present. I hope you still remember these 4 criteria, which are fever, thrombocytopenia of less than 100,000, hemorrhagic tendencies, and plasma leakage. There were studies which showed that 14 to 22% of those with shock did not fulfill all 4 criteria, which are considered necessary for the diagnosis of dengue hemorrhagic fever by the WHO in 1997. Likewise, the old classification has a low sensitivity in detecting dengue hemorrhagic fever, since many dengue shock syndrome do not have platelet count of less than 100,000. Hemorrhagic tendencies do not reliably differentiate dengue fever and dengue hemorrhagic fever. Also, the increase in hematocrit is not seen after IV fluid therapy in patients with poor perfusion, severe bleeding, and anemia. Having said this, the Department of Health has adopted the new WHO dengue classification with and without warning signs, severe dengue with severe plasma leakage, severe hemorrhage, and severe organ impairment. The WHO classification released in 2009 has been adopted by the Philippine Department of Health into an administrative order released in March 12, 2012. Moving on, we are now ready to manage our patients presenting with 2 to 7 days fever with or without warning signs or signs of severe dengue. There are 3 phases recognized in the clinical course of dengue, which are the febrile phase, critical phase, and the recovery phase, which we are going to look into in the next slides. In the febrile phase, patients would have fever from 0 to 7 days, which can have a possible biphasic pattern. Constitutional symptoms may start to be manifested during this period due to the viremia. It is important to monitor the effervescence or lysis of fever during this time and be vigilant in checking for the presence of warning signs to recognize the start of the critical phase. In the febrile phase, there is sudden onset of fever plus any of the following: severe headache, retroorbital pain, myalgia, rash which can be transient, macular, or even maculopapular. There can be minor hemorrhagic manifestations in the form of petechiae, purpura, or epistaxis, and even hematuria. During the febrile phase, if you do a tourniquet test, this can be positive. Patient may also present with facial flushing, anorexia, injected oropharynx, and in the laboratory test, you can see leukopenia or a mild to moderate thrombocytopenia, which can be more than 100,000, and elevated AST, ALT. If you do a serum sodium test, there can be hyponatremia, which can be due to the decreased intake during the febrile phase. With regards laboratory findings during the febrile phase, patients can have leukopenia, thrombocytopenia, and hemoconcentration. Please note that during this phase, WBC count may be noticeably low as compared to the platelet count. For the confirmatory test, this is the best time to request for the PCR or even virus isolation because this is also the time when viremia happens. On the other hand, dengue NS1 antigen test, which I mentioned earlier is an optional test, can also be requested during this phase. Problems that should be recognized during this febrile phase are the following. Patients can have dehydration, hyponatremia, febrile seizures, and neurologic problems such as aseptic meningitis and encephalitis. Please note that these are not complications but part of the febrile phase which should be recognized. Other infectious diseases can also mimic dengue since these conditions may also present with fever and rash. It is important to recognize these other infectious diseases in order to provide appropriate management. You can see in this slide that different viral infections, bacterial infections, parasitic infections such as malaria, febrile illnesses accompanying with rash such as measles and rubella, and diarrheal diseases caused by rotavirus, salmonella, and other enteric infections should be ruled out during this febrile phase. Moving on to the next slide on the critical phase, which can happen as early as 3rd day after onset of fever up to the time of defervescence. At this time, patient may develop severe disease and may become critically ill. This can keep us pediatricians awake at night. However, some patients may improve during this phase and may not develop severe disease. During this critical phase, there would be a rapid decrease in platelet count, which is associated in the rise in hematocrit. At this time, those who would develop severe disease will have manifestations of warning sign, which I hope you still remember. And these are severe abdominal pain, liver enlargement of more than 2 centimeters, persistent vomiting defined as more than or equal to 3 episodes within 24 hours, mucosal bleeding, lethargy or restlessness, and if you still remember, leukopenia or moderate to severe thrombocytopenia and hemoconcentration are also considered as warning signs in dengue. During the critical phase, patient may also present with progressive organ impairment, metabolic acidosis, and DIC. During the critical phase, laboratory findings or laboratory changes that can happen include the following. The WBC, which is represented by the solid black line, you can see that during the critical phase, you can have severe leukopenia. And platelet count can also be very low during the critical phase. The hematocrit, which is represented by the broken violet lines, you can see that during the critical phase, you can have severe hemoconcentration. There are also conditions that mimic other infectious diseases during the critical phase of dengue. So you can have acute abdomen. Differential diagnosis will be acute appendicitis, acute cholecystitis, perforated viscous, or even diabetic ketoacidosis. So I hope you remember that one of the severe signs of dengue is the severe abdominal pain. Patients during the critical phase can also have acidotic breathing or respiratory distress, which can also be present among patients with diabetic ketoacidosis, lactic acidosis, renal failure, and acute respiratory distress symptoms. Infections can also be entertained, which is very similar to the manifestations during the critical phase, which you can see in the slide. Autoimmune diseases can also be considered when patients are in the critical phase of dengue. Malignancies, such as acute leukemia or lymphoma, should also be considered because your patient can present with severe bleeding during the critical phase. Other conditions may also mimic critical phase of dengue, such as liver cirrhosis. The clinical problems of critical phase of dengue can also be very difficult to recognize and to manage. These are hypovolemic shock due to plasma leakage or end organ impairment from prolonged shock. Because of this, your patient can have myocarditis, severe hepatitis, encephalopathy, or even renal failure. Another very difficult problem encountered during critical phase is the severe hemorrhage. Looking at the recovery phase, this follows the critical phase where patients can have gradual reabsorption of the extravascular compartment of fluids within 48 to 72 hours. If you can see in your slide, recovery phase can happen from 3 to 5 days from the time patients will have the critical phase. In the recovery phase, there are different clinical manifestations, laboratory findings, and clinical problems which you can see in the slide. I'm sure you're all very familiar with the rash described as isles of white in sea of red, which you can appreciate when patient is on the recovery phase. And we're all happy to see this kind of rash because it means patient has been managed adequately, and in few days you will be able to discharge this patient. During this phase, you can see that patients will have improvement in the general well-being and even improving appetite. The GI symptoms, such as the severe abdominal pain, will start to subside during this phase. Likewise, hemodynamic status stabilizes during this time and diuresis improves. Patient can also present with generalized pruritus, and I know sometimes we prescribe antihistamines in order to address this generalized pruritus. What is very critical, I would say, during the recovery phase is that patients can have bradycardia, and ECG changes can also be common during this time. When you look at the laboratory finding, during the recovery phase, the hematocrit stabilizes or is slightly lower due to the dilutional effect of the reabsorbed plasma. So nothing to worry if you see that the hematocrit turns out to be lower. The WBC also will start to rise during this time, and the platelet count increases at the same time as the WBC recovers. So you can see during the recovery phase, the leukopenia starts to improve. Likewise, the thrombocytopenia also starts to improve. However, there are clinical problems that can be encountered during the recovery phase. One is the hypervolemia due to the excessive fluid therapy initiated during the critical phase. Because of this hypervolemia, patients can also have acute pulmonary edema. Organ impairment due to prolonged or refractory shock leading to ischemic hepatitis and hepatic encephalopathy can also be seen during the recovery phase. Because of prolonged hospital stay, patients can also have nosocomial infections which may warrant antibiotic treatment. After our discussion on the different classification of dengue, as well as the different phases of the disease, we are now ready to manage our patients. Fluid management for patients with dengue without warning signs, or this is equivalent to the dengue fever or dengue hemorrhagic fever, who are not admitted in the hospital. These patients should be given oral rehydrating solution with the following. Depending on the body weight, patients will be given equivalent volume of ORS. Example, if your patient weighs between 10 to 20 kilograms, this patient should be given ORS in the amount of 75 ml per kilo per day. For dengue fever without warning signs, without shock, this is equivalent to dengue fever or dengue hemorrhagic fever, grades 1 to 2. Patients should be given only isotonic solutions such as 0.9 sodium chloride or Ringer's lactate solution with or without glucose. For infants less than 6 months, patients should be given D5.45 sodium chloride. Maintenance IV fluid can be computed using the caloric expenditure method or the holiday cigar method, which you can see in the slide. So for example, your patient weighs 8 kilograms. The maintenance IV fluid that should be given is 100 ml per kilogram. But if your patient is from 10 to 20 kilos, so you should give 1000 ml plus 50 ml for every kilogram more than 10 kilos. For patient with signs of mild dehydration but is not in shock, we have to add the volume needed for mild dehydration to the maintenance. For infant, the volume that has to be added is 50 ml per kilo, and for older children or adult, it's 30 ml per kilo. So remember to add this mild dehydration from the maintenance IV fluid that was shown earlier. The volume should be given in 24 hours, and we have to monitor the clinical parameters correlated with the hematocrit. Likewise, as a warning, maintenance fluid should not exceed 3 liters per day. For patients who are admitted with warning signs but without shock, the rate of infusion that is recommended is as follows. So start with 5 to 7 ml per kilo for 1 to 2 hours, then reduce this amount to 3 to 5 ml per kilo for 2 to 4 hours, then reduce to 3 ml per kilo per hour or less according to the clinical response. So it's very important that during this time, I&O or monitoring of the amount of fluids that is infused to the patient should be monitored in order to appropriately reduce depending on the clinical response. Patients who are admitted with warning signs but without shock, we have to reassess the clinical status and repeat the CBC. If the hematocrit remains the same or rises minimally, we have to continue the same rate. For example, you are giving 2 to 3 ml per kilo per hour, then you have to give the same amount for another 2 to 4 hours. However, if vital signs worsen, and you can see that the hematocrit is rapidly rising, we have to increase the rate to 5 to 10 ml per kilo per hour for 1 to 2 hours. So there's no need to be afraid to give this amount as long as you're monitoring the vital signs and you're also seeing rapidly increasing hematocrit. You have to give the minimum amount of IV fluid required to maintain good perfusion and urine output of 0.5 ml per kilo per hour. IV fluid usually is not needed after 48 hours, meaning IV fluid therapy should be administered only in 24 to 48 hours with strict monitoring of the vital signs as well as the hematocrit. IV fluid should be reduced gradually when the rate of plasma leakage decreases towards the end of the critical phase. Laboratory investigations in both shock and non-shock when there is no impairment in spite of adequate volume replacement. So if you can see in this slide, you can check at which point you need to increase or decrease the IV fluids depending on the monitoring of your vital signs as well as the hematocrit. So if needed, before reducing the rate of IV replacement, the clinical condition, the vital signs, the urine output, and hematocrit levels should be checked to ensure clinical improvement. I would like to direct you to the box on the right. So if you can see, transfusion is recommended only if there is decreasing hematocrit, and if you need to transfuse, the volume recommended is at 5 to 10 ml per kilo of your packed RBC or 10 to 20 ml per kilo of the whole blood if there is severe bleeding. If patients are not improving despite adequate fluid therapy, we have to check for the ABCs of dengue. A stands for acidosis, B stands for bleeding, C for calcium, and S for blood sugar. To repeat, despite adequate resuscitation of your IV fluids, your patients are not improving. You have to check for these ABCs. For acidosis, you have to request for your blood gas. And if there is acidosis, this indicates prolonged shock. Organ involvement should also be looked into by requesting your liver function as well as your BUN and creatinine. Adequate fluid resuscitation will not address bleeding. As mentioned earlier, you need to transfuse blood, either packed RBC or fresh whole blood if there is severe bleeding. You can have a hint if there is bleeding if hematocrit decreases as compared to previous or is not rising. You need to do cross-matching for a possible transfusion. Hypocalcemia can also be another problem in dengue, which is almost all cases of dengue hemorrhagic fever, but patients with hypocalcemia might be asymptomatic. In cases of hypocalcemia, we need to give calcium supplement at a dose of 1 ml per kilo, diluted 2 times, and given a slow IV push. We also need to check for blood sugar since most patients with severe dengue will have poor appetite together with vomiting, which can cause hypoglycemia. And those patients with impaired liver function may also have hypoglycemia, and some patients may actually present with hyperglycemia. Thus, it is very important to monitor the blood sugar level. Some key points in IV fluid therapy. You will know whether you're giving inadequate IV fluid, adequate IV fluid, or excessive IV fluid. This makes management of dengue very challenging. You don't know how to titrate or how much do you need to give, whether you're giving inadequate, adequate, or excessive IV fluids. If you're giving inadequate IV fluids, your patient can have hypovolemia, which can lead to compensated shock or even decompensated shock. They can have bleeding, not necessarily secondary to dengue. They can have DIC or multi-organ failure, not necessarily due to dengue per se, but because of inadequate fluid that is being given, especially for patients who are in the critical phase. How would you know if you're just giving adequate IV fluids? So with the IV fluids that you're giving, depending on the weight, your patients can have improved circulation and even tissue perfusion, manifested as decrease in hematocrit level up to the normal level. Your capillary refill time will be 2 seconds. Patients will have normal heart rate. You're giving adequate IV fluid if the urine output is maintained at 0.5 ml per kilo per hour. You will have normal blood pressure or even normal pulse pressure and improve in acid base. Of course, we want to be assured that what we're giving is adequate fluid therapy. In dengue, we also have problems of fluid overload manifested as pulmonary edema, respiratory disease, or even worsening of the pleural effusion and ascites. This happens especially during the recovery phase, and we're still giving very high IV fluids. So you can encounter problems of fluid overload. Now, how do we address if we were successful in managing our patients and your patients are now in the convalescent period? The key features of patients in convalescent period is the improvement in the appetite and the general well-being of your patients, and likewise improvement in clinical parameters. We will all be happy to see our patients smiling again, eating, and of course, when we look at our hematocrit, you can start to see a decrease going to the normal level of your hematocrit and also an increase in the platelet count. What are the other signs of recovery of patients with dengue? You can see a stable pulse. The blood pressure and respiratory rate are also stable. The temperature will be normal. There is no evidence of external or internal bleeding. The appetite will return to normal. There will be no vomiting or abdominal pain. Patients would have good urine output. The hematocrit will be stable and return to the baseline level. And convalescent petechiae or itching, especially on the extremities, can all be manifested during the recovery. How do we manage patients at this phase? Very important to discontinue IV fluids. We have mentioned earlier that you can encounter excessive overload if IV fluids are still continued during the recovery phase. If the patient is hemodynamically stable and out of the critical phase, which was mentioned as from 1 to 2 days from defervescence, we have to stop the IV fluid and closely monitor. If necessary, during this time that patients will have fluid overload, you can give oral or IV furosemide at a dose of 0.1 to 0.5 milligram per kilo per dose once or twice daily, or a continuous infusion of 0.1 milligram per kilo. During this time, we mentioned that patients' appetite is already improving. Thus, we have to encourage intake of oral fluids. So, it is very important also to decide to discontinue IV fluid during this time. We also have to continue close monitoring during the recovery phase because during this time, patients can have hypokalemia or even bradycardia. For hypokalemia, you can address this by giving potassium-rich food or supplements such as Kalium Durul or even bananas. One important manifestation of patients during the recovery phase is they present with bradycardia. So this can be addressed by advising patients to go on bed rest, and this may require intense monitoring for possible rare complications such as heart block and ventricular premature contraction. So if you do an ECG, heart rate may be as low as 50. If needed, you may refer your patients to the cardiologist. During this recovery phase, patients may be advised to limit the activity. You can also have variable arrhythmias observed during the convalescent period, and we will also be discussing what are these laboratory tests which you can check during the recovery phase. For the limitation of activity, patient will be advised to have bed rest, especially those who are diagnosed to have dengue fever or dengue hemorrhagic fever, because this may be complicated by myocarditis during the convalescent phase. Physical activity after discharge is restricted anywhere from 2 to 4 weeks up to 6 months, depending on the severity of the myocarditis. During the convalescent phase, patients can also have arrhythmias. So how do we address this? So manifestations of arrhythmias during the convalescent phase, they can have sinus node dysfunction, manifested as sinus bradycardia, or even first-degree AV block. During this time, you may request for an ECG or even cardiac enzymes, chest X-ray, and serum electrolytes. Now we're ready to discharge our patients. So, how do we know whether our patients are ready for discharge? So, there are two parameters, the clinical and the laboratory parameters. So, for clinical, you know that your patient is ready for discharge if patient is febrile for 48 hours, there is improvement in the general status, such as improvement in the general well-being. You can see your patient smiling already. The appetite is improved. The hemodynamic status is stable. Urine output is adequate. And there is no respiratory distress. At least 2 to 3 days have elapsed after the recovery for shock. You're now ready to discharge your patient. And when you check the laboratory, platelet count will have an increasing trend and the hematocrit will be stable even without the IV fluids. Now that we are ready to discharge our patients, what are the advice that you can give them? For uncomplicated cases, Trauma should be avoided. Involvement in aggressive sports and behavior should be avoided 3 to 5 days after discharge because there can be still risk of bleeding if this trauma shouldn't be avoided. Likewise, platelet usually rise in 90% of dengue hemorrhagic fever and dengue shock syndrome cases within 7 days after the critical period, meaning you can discharge patient even if the platelet count is not normal as long as you can see a trend in increasing platelet count. If people in the same house or around are sick with high fever, you have to advise that they should seek consultation in order to check for the presence of dengue infection. It is also very important to teach the patients and the families on how to prevent dengue at home and in school because we mentioned that there are 4 serotypes of dengue and immunity is achieved only for a specific type of dengue virus. Now we're ready to give the final diagnosis of the patient we mentioned earlier. So the final diagnosis for this patient is dengue hemorrhagic fever grade 3, or in the new classification, patient has severe dengue with shock. This is my thank you dance to everyone. Please answer the post-test. You need to answer the pre and the post-test to earn the CPD points, all for the Filipino child. Thank you very much.